Okay.
Oh, okay, another, all right.
Use that 2 videos.
Okay, all right, so now what we're looking at is we don't do vasopressin anymore, because vasopressin is nothing more than ADH, which is your antidiuretic hormone, which you secrete anyway. So it really wasn't doing much, so we don't give that anymore. So everybody gets the stuff in the green. If it's a non-shockable rhythm, it's either gonna be asystole or PEA. Asystole, end of life, we're all gonna be in it someday. All right, it's just the way it works. Now, what we wanna look at is our H's and T's. What caused their heart to stop? That's the big thing. So when we look at it, is when, especially PEA, because what PEA is this. You have 3 layers to your heart. The outer layer, which is your blood supply, your coronary arteries. The middle layer, which is the muscle, which causes the contraction. And then the inner layer, which is your electrical system. Well, in PEA, the electrical system works just fine. Why isn't it getting the message to the muscles to make it contract? So I need to really figure out what's going on with these patients. So now what we do is we look at our H's and T's. Is your patient hypoxic? Are they hypoglycemic, hypovolemic, hypothermic, hyperkalemic, hydrogen ions, meaning they're acidotic? Was it a trauma? Is it a tamponade, a thrombosis, tension pneumo, or tablets? Hypoxic, you start bagging them adequately, you're going to take care of that, and you're going to take care of the acidosis right off the bat. Anybody who's not breathing is going to be acidotic. You're not blowing it off. Hypoglycemia, check the blood glucose level. Hypovolemia, give fluids and get a history. Hypothermic, they're not dead until they're
Warm and dead.
warm and dead. And where'd you find them? You know, that's a big thing too. Hyperkalemia, where'd you probably pick your patient up at?
Dialysis.
CDC somewhere. Especially, you know, that's what we're looking, if, you guys are getting one, right?
Good thing we don't
And then
have
we
it.
look at our traumas, all right? Your tamponades, your tension pneumos. Now remember, their heart's not beating. So you may not have all the signs and symptoms that you normally would. All right, so make sure you listen to lung sounds. With the tamponade, look at the history, look for redness, things like that. Thrombosis, did they throw a clot? Are they having was this a massive MI and they got a myocardial rupture? Did they have a stroke? Is it a PE? And then tablets, you know, overdoses, things like that. So that's what you're looking at. Okay, so get those, and realistically, these H's and T's are done with everybody. You don't save them for just when they're in cardiac arrest. You know, you do them all the time, you're starting to think about it. So that's what we're looking at. All right, so again, only meds that we are going to use is amiodarone, and that's for somebody who's in B fibra, pulsus VTAC. Other than that, everybody gets epi. Now, let's say you get them back. So we're in ROSC now, which is good, because when you got there, they didn't have anything. Now what we need to do is look at our patient. Are they bradycardic? Are they hypotensive? If they're bradycardic, you go back to the bradycardia protocol. You may have to pace them, you might have to give atropine, but I gotta get that heart rate up. Right. If they're hypotensive, give them fluid till their blood pressure becomes 90 systolic, and you should be good, and then you might have to start a dopamine drug. Now, if you converted them electrically, which means you gave them a shock and they converted, we don't have to do anything. Just supportive care only. We don't give an amiodarone drip. We don't do any of that stuff. Now, if you converted them with amiodarone, then you need to continue it, and that's going to be 150 milligrams and 20 mLs over 10 minutes. And this is all in your protocol too. So, you know, if you used mag sulfate, we're not going to give that in your ROSC, just because you have to be careful with mag. You'll start to see PVCs with magnesium sulfate. Your patients might complain of muscle problems, things like that. So kind of let the hospital do a mag drip.
They sell that pre-mix now.
What, your mag?
No, the amiodarone.
That's nice. You guys have it, it's nice. You guys, are you guys carrying premix?
I don't know, are we?
I don't know.
I doubt it.
I don't know.
I doubt UH is gonna buy it.
We're on tape.
Come on, man.
I still doubt they're gonna buy it.
I don't know. I don't know.
What?
It's always a surprise when you open up the drug box, excuse me. Now,
Dan Ellenberger, did you hear that?
so post-resuscitation, again, we're in ROSC, but hypothermia. Should we induce hypothermia? Well, the only time you're going to do it is if your patient's unresponsive, or if they respond only to pain. If your patient is verbally answering you or they're wide awake, do not make them cold. All they're going to do is drive you nuts by asking for a blanket. They don't need it. The only reason you're inducing hypothermia is in somebody who doesn't come out of that cardiac arrest when you get them back and you wanna give their brain a chance to heal a little bit. It's almost like a mini mammalian diving reflex. They just wanna shut everything down. If you're going to do this, you can use your, they have the cooling collars, which are nice, but you know what, save your money and just get some ice packs. Put them on put some ice packs. You can put a piece of tape around them with a towel there, and you can do that. You can put ice packs under the arms and the groin. The biggest thing to remember is if you start the induction of hypothermia, before you do it, call the hospital and make sure they can continue it. If they can't continue it, then you don't start it. It doesn't do them any good. Does that make sense? Because, they're the ones who are gonna be doing all the other stuff with the blankets and things like that. So if you can't, it's just like you got a frostbite hand, you're not gonna thaw it out and then refreeze it. It's the same thing. Don't start hypothermia if they can't. So make sure you're calling the hospital when you, before you start that. Okay, and there's your collar. Like I said, you can buy the collar or you can just make your own. All right, so that was it for adults. Any questions? Because now we're gonna go on to peds. Peds is a little bit quicker because of the fact we've explained everything during the adults. And the biggest thing with pediatric patients is most of them are born broken. Most kids don't just stop. All right, I don't know what happened. They just, no, that doesn't work. It's different if it's 85, 90 years old, but you got an 8-month-old here. They usually don't stop. So something's wrong. So let's look at this. We've been involved in a field delivery. Child's born at 37 weeks, so they're good. Mom's stable, but the baby is in distress. Has central cyanosis, is limp, and breathing only 8 times a minute. Those 3 things are huge, because first off, I don't want central cyanosis. I want pink baby. I expect the peripheral to be cyanotic because they've never circulated blood before. So it's going to take a few minutes. But centrally, I need them pink. Limp, kids are made of sugar. They're sugar, kids are nothing more than sugar with noise and dirt on them. They should not be limp. All right, and breathing 8 times, a normal newborn breathes 40 to 60. We have a huge problem here. They're never going to get pink with a respiratory rate of 80, or of 8 rather. So let's look at our neonatal resuscitation. You guys all remember the inverted triangle. The big thing about that is meds are always at the bottom. Again, these kids are not usually born broken. Top warm and dry. Make sure you dry these kids off. A cold baby is a dead baby. And don't wrap the baby up in the towel you dried them off with, because they're still going to be cold. It should actually be, you should be sweating profusely in the back of the squad when you deliver a baby back there. Turn the heat up, because babies can't shiver. They're brand new. They don't have that ability to keep themselves warm yet. So keep them warm, suction them if you have to. You can do your APGARs at 1 and 5. Your average APGAR for a baby who's moving around and crying when they're born is 8. I don't care how much an overachiever your child is. No one's going to be a 10 at 1 minute. You just haven't had a chance to circulate things. Usually it's 8 and 10. 10 will be after 5 minutes. So what we're looking at is this baby is breathing 8 times a minute. They're cold, they're limp. So we need to start bagging them right off the bat. All right, heart rate's probably going to be low. It's going to be less than 100, so we're probably going to have to do compressions as well. So it's 1, 2, 3, breathe, 1, 2, 3, breathe, 1, 2, 3, breathe. The biggest thing you have to remember with this, when you start bagging a newborn, for the first 30 seconds, you only use room air. They don't need 100% oxygen. Because remember, they've never used oxygen before to breathe, so we all breathe at 17%. Well, all of a sudden, I'm getting this newborn who has never used oxygen before. They're human. It's not like she just gave birth to a different species. So this baby's designed to breathe in 17% of oxygen. All of a sudden, I give them 100%. What do I do to their teeny tiny little blood vessels? I vasoconstrict them. So for the first 30 seconds, just give them room air. They don't expect a newborn's SpO2 to be 95 until they're 10 minutes old.
Is there a chance of knocking out their drive too with that high of oxygen or no?
Not really knocking out their drive so much, it's that vasoconstriction. So think of like preemies. A lot of the preemies get, they have problems with their eyes because the retinal arteries and vessels, they vasoconstrict with all that excess oxygen. They get that O2 toxicity. So that's why for the first 30 seconds, bag them at room air. I mean, these kids have never done this before. They just might need a little bit of a push. Come on, let's go, let's go. You know, the kids, a little PO because it was nice in there, and now people are yelling, and it's cold, and all that. Just start bagging them. Hopefully that's what'll happen. Now, if after 30 seconds it doesn't work, well, then we go on. All right, now we've got some issues. We may have to bag, we're gonna have to intubate the patient. You know, now once we start intubating, now we're increasing oxygen, things like that. But for the first 30 seconds, just do room air, because that's what they're designed to breathe off of. And I don't wanna vasoconstrict things. Okay, so then we keep going. You know, if they're effective, great. If they're not effective, then I keep moving on, and I keep reassessing. I might end up being just by blow-by, and then by the time we get to the hospital, kid's crying, and he's pink, and his heart rate's up, and everything's fine, and then give him a name and all that stuff. But the key is begin that, you know, right off the bat. So start that 30 seconds. You know, you might have to give some sugar. Narcan, iffy, it's gonna depend on mom. The problem with Narcan is if mom's a user, baby's a user too. So you can really throw that kid into withdrawals. You know, that's a NICU baby that's gonna be forced to go through withdrawals. 20, 30 days, things like that. So you wanna be real careful with that. All right, so next one for the pediatric patient. Respond to a call for a 15-month-old who's semi-conscious. You find the child in the room. He's pale and does not acknowledge your presence in the room. Now, I know that's how presents are. I don't know what you're bringing them, but no gifts. All right, it's supposed to be presents, not gifts, okay? So leave your gifts in the squad. Mother states she found him that way when she went to wake him up from her longer than usual nap. So he's 15 months old, quiet 15 months old. Is that normal?
No.
No. Oh my God, my kids used to have T-shirts that said, "If I'm quiet, you better find me." And when I found them, it usually wasn't good. They were either eating butter or drinking Windex or living in cars. I mean, God knows. But the thing is, this is not good. All right. So pulse is 68. Respirations are rapid and shallow. No BP because of the age. Don't waste your time right now. SpO2 is 88. Oxygen and heart rate go hand in hand with kids. Not that they don't with adults, but in kids they really do. So initial EKG. He's 15 months old. Are you a little nervous about that?
Way too slow, yeah.
That's way too slow. All right, so we need to get moving fast. So what do we need to do? We need to get that airway under control. We need to oxygenate him. Get a history. Get capnography on there. And now what we're going to look at is he stable or unstable? Well, he right now is not stable. Okay, we do not want to have to pace him if we can help it. All right, because this is a brand new heart. It hasn't gone to McDonald's yet. You know what I mean? It's brand new. So what we want to do is we'll start CPR if the heart rate's less than 60. We'll start doing our compressions. Then we're going to give epi, 0.01 milligrams per kilogram or 0.1 milliliters per kilogram. Personally, I think this is the best way you should do it. Use your Braslo too. Braslo tape. Do that every 3 to 5 minutes. You'll max out at 1 milligram per dose. Okay. Make sure it's 1 to 10,000. Do not give them 1 to 1,000 to the IV, right, ever. That doesn't work, you can consider atropine. Atropine really, with a pediatric patient, atropine runs off of, again, it's a parasympathetic. Well, there's nothing wrong with the kid's vagus nerve. It's a brand new vagus nerve. So unless you cause the bradycardia, like let's say you go to intubate and you stimulate the vagus nerve and you can't get the heart rate back up with bagging, atropine might work in that situation, okay? That doesn't work, pace. Where will you be if you are actually putting pacer pads on a 15-month-old because their heart rate's too slow?
Hopefully at the hospital.
Thank you. Okay, and then we go to the hospital, all right? Even the hospital would be like, what? Make sure you call them and let them know, okay? So scenario 3, you call to the house for a 4-month-old infant who is abnormally fussy with poor feeding. On arrival, the child is being held by the mother, has a rapid respiratory rate, skin color is good, cap refill's good, it's less than 2 seconds, pulse is too fast to count, baby's crying and active. Best sound in the ER is a crying baby, unlimited oxygen. So right now we got a little bit of time to figure out what's going on. Oh, put him on the monitor. And we're close to 300, we're at about 280.
It's too fast.
It's way too fast.
Way too fast.
When you look at an infant, an SVT, anything greater than 220. Child, kid's maintaining it. Remember we did that experiment with the underwear where we stretched out the elastic? That's the same thing. He's got great elastic right now, but once it snaps, if we don't fix it, we're in big trouble. So what do? He is stable at this point, so we can do a vagal maneuver. Now, a 4-month-old or an 8-month-old or a 15-month-old is not going to know what it means when you say bear down like you're having a bowel movement, right? They're just going to stare at you. Ice to their face. Now, this isn't when we take the kid and put them in ice. Put ice packs on their face. Yes, that's all. I'm sorry, but I have to specify this stuff. People ask. You know, like the tourniquet goes above the wound, not below. So the same thing. Don't put them in ice. Ice to their face. Hopefully that'll help, because they'll do that, and they'll go down. Now, if it's an older kid, toddler, have them be a monster, they go like this, they'll bear down. If that doesn't work, we'll give a Denison, 0.2 milligrams per kilogram. Max dose is 12. Give fluid if they seem dehydrated. And remember when we talked about shock, 15-month-old doesn't have 5 to 6 liters. So it doesn't take much for them to lose fluid if they're sick. Now, if they're unstable, we have to cardioversion them. Sedate them if you can. You're going to start your cardioversion 0.5 to 2 joules per kilo, and you're going to repeat. Okay? Explain it to the parent what you're doing. All right? Because, again, kids come with packages in terms of parents or caregivers. So you've got these family members, and they don't know what's going on. There's nothing wrong with letting them be in the back of the squad as long as you set your perimeters. You can sit here with us. I mean, you guys all have kids. If you don't, you have little ones that you care about. You don't want to leave them alone, but you have to set perimeters. I can't, you have to give me the baby, and you can sit here and I'll tell you what I'm doing, but I have to take care of the baby. So anything that's poor perfusion, mottled skin, lethargic, delayed cap refill, weak brachial pulse, they're going to get cardioverted, and that's what we talked about here. So you'll cardiovert them, and hopefully that will do what? And a nice rhythm. And then our last scenario, this is the one I don't know why, I just have a sick sense of humor. Call to a local daycare for a 4-year-old female who doesn't feel well. On arrival, patient is sitting in a chair. She's scared by your presence. I'm not sure what you gave her, but stop, because she's crying now. So we need to spell check some of this stuff. So no gifts. All right, caregiver states the child did not want to play this morning. She noticed the child seemed to be breathing rapidly and that the child has a history of an unknown heart disease at daycare. So I'm a little concerned about everything at this point because I don't know what's going on. All right. So skin color's normal, so we're good. We know right now perfusion's okay. Cap refill's less than 2 seconds. She's got a radial pulse, so she's got the perfusion. You put her on the monitor, and that's what the 4-year-old monitor. So you're going to do a double check and check your leads, and we're like, okay, now we've got a wide complex tachycardia. What's going on? We know it's coming from the bottom of the heart because it's wide QRS. So what can we do? We can attempt vagal maneuvers. She's 4, so we can't do that. Bear down to C. And then we're going to give amiodarone. You get 5 milligrams per kilogram. Max dose is 300. You're going to mix this because the patient does still have a pulse. So it's going to be over 20 to 60 minutes. Child is stable. You're also going to give fluid in case it is something that maybe they're dehydrated. If they are unresponsive or they've got signs of poor perfusion, such as we talked about earlier, we're going to go into the unstable, which means they have to be cardioverted. You'll start at 0.5 to 1, work your way up. And hopefully somebody's trying to get a hold of who? Mom or dad or whoever, because a wide complex tachycardia. And realistically, I need to start asking questions. Did they take anything? 4-year-old, did you get into somebody's medications? What did they take? What's going on that the QRS isn't doing it? So really look for those tablets and start thinking. And remember, kids will eat shoes if you let them. I mean, they don't care really anything, So a pediatric cardiac arrest is the same thing in an adult. Again, it's shockable, non-shockable. PEA, asystole versus VFib pulses VTAC. With arrest, asystole is going to be your most common in a pediatric patient, simply because in a pediatric patient they go to respiratory arrest, then they go to cardiac arrest. Again, they're brand new hearts, so unless they have a history and they've got a zipper and a medical file this big, most kids' hearts just don't stop. Something caused it. So, the cardiac arrest protocols, still the same thing if you're still gonna give amiodarone and shock. It's a pediatric patient, so if it's a shockable, they get amiodarone, they get a defibrillation. You start at 2 joules, then you go to 4 joules. Your amiodarone, 5 milligrams per kilogram. If it's asystole or PEA, consider your causes and you stick with your epi, which is really good CPR.
And hopefully we're pulling into the hospital.
Yes.
That's my one.
Things to remember, use your Broslow. Really, really use your Broslow. It's such a great tool. I mean, and you know, most kids really do kind of match them. I mean, you're always gonna have the kids that kind of go over, but for the most part, the bulk of them will match up. It tells you down to the dosage. You know, you've got hyperlinks in your protocol that you've seen that will go back and show you what you're supposed to do as far as, you know, how much meds and things like that. So make sure you use your hyperlinks if you need them. That's about it, you know, and then again, your Broslow is done by colors, you know, so that's what's nice is these hyperlinks, you know, if your kid weighs between 10 and 11 kilograms, you can hyperlink onto that thing, it pulls it up, and it gives you the dosages for all the drugs, what your defibrillation setting should be, everything, you know, so it really is a good tool to use, and then here's what it looks like. So it shows you all the drugs, how much you should be giving, so it really takes a lot out of it for you. You know, that's a little bit of a more frantic call. I mean, I know you're being paid not to panic, but still, you've got a whole bunch of people there, you know, you're not in your normal environment, so use these tools, because they really are a good thing to use.
We don't get enough pediatric calls to be comfortable in that.
Right, and well, nobody should ever really be comfortable with pediatric calls, it's just, there's so much, it's so chaotic, and again, you've got people and all this other stuff, so really use them. So we've talked about asystole, PEA, you know, our VFib and pulse SB-TAC we've already talked about. You know, so your post-resuscitation care is the same, you know, as far as that goes, except your dose for amiodarone changes. That's it. So let's do our case of the month. This is gonna tie into what they were talking about as far as the glucometer. Big thing with the glucometer is that some of you might remember when you used to start the line and you would, you know, as you had a little drip of blood and you would do your glucose check there. Don't do that anymore if you're still doing it. I haven't run into anybody who's still doing it. Don't do it because your venous blood and your capillary blood is different, and your glucometers are actually calibrated for capillary blood. So that's why sometimes if you do a venous stick, or you even use the flash blood and do it, it may be different than what they get at the hospital, and then you're getting yelled at. Well, you know, no, his blood sugar was this.
Nobody's ever told me that before.
Yeah,
I didn't
it's
know
I always
completely
think so.
different. Yeah, no,
How
don't
different
use,
could it be?
it can be up to
That's
40 to
nice.
60,
Oh, really?
depending, especially your elderly patients.
Okay.
So yeah, don't use,
Why that slipped through the cracks all this time?
yeah,
Whoops.
don't use venous anymore, it's all capillary.
Okay.
Now, we did an experiment at Cleveland Heights, I had them check I had them start a line and do it here, and then I had them do a capillary, and it was different. It was about 15 points off. So, you know, and it was just to show them, you know, but it's like.
Lower?
I don't want, this one was higher than this, which was weird.
Well,
Yeah.
sure, especially if you have obviously like a diabetic, that it hinges on that correct reading, you know?
Right, so that's why, especially your elderly patients, it's off. So you might get it here and it might be like 74, and you're like, oh, okay, good, and he's still kinda off, you get him to the hospital and they do this, and the blood sugar's 40 too.
You know, that you bring that up when you go to a nursing home and the crazy event, they do a sugar check there before you get there. It's usually different, and they're gonna do it that way.
Yeah,
and we
all
get 'em
your
in there,
machines, all your
There you go.
I
machines,
checked
yeah.
here, and I'm like, well, they were off by quite a bit.
Yeah, all your machines are calibrated for capillary blood.
So you're saying that they don't suck as good as we think they suck?
Yeah.
This whole time we've been calling.
Yeah, you've been calling them names, and here it's
I feel
like,
bad.
my bad, oops.
The red
Yes.
letter to them.
Yeah, all your glucometers, even in the hospital, are calibrated for capillary.
Huh.
So make sure, you get out of that habit of doing this.
Does that come in the book that comes with the machine that says
Yes.
that?
Yeah, it should, I mean.
Whoever sees the book to
Yeah.
kill them.
Yeah.
Yeah, that's
You
thrown
can
off to the
find
side,
the-
it's gonna be good.
no, this is instructions, remember what I told you, you guys would listen to them if they were in like Darth Vader voices and stuff like that, or, you know, but, yeah, all your glucometers are, capillary.
Get LT done to, send out an email to everybody on that.
So now we're gonna talk
Yeah,
about it in
maybe.
a few minutes. Alright, so here we go. You're called to the scene for an 80-year-old with an altered mental status. He feels shaky, he quickly goes unresponsive, your initial evaluation. Anytime you have somebody with an altered mental status, or AMS, you wanna go AEIOU tips. That's just a little mnemonic. So A, it's either alcohol or they're acidotic. E, they have epilepsy and they're postictal. I, insulin, they're diabetic. O is overdose. U, uremic, so they're a kidney failure. T is a trauma, so lack of, fluid. I, an infection, so they're septic.
Boy.
P is psychosis, so they're kind of cray-cray, and then a stroke.
We needed this on our call this morning, because we weren't sure what this guy,
Well, that's what you
like, we
look
had
at.
to run through all that stuff
Yeah.
almost, just to see what was going on.
So
with it.
that's-
We gave him Narcan.
Yeah,
We
well,
checked
we're
his
doing-
sugar.
yeah, I mean, that's
Thought
an
he was
altered
broken,
mental
yeah.
status. You're,
He could have been nuts.
The doctor looked at his tongue and said it was really white, she thought he was anemic, possibly.
well, I know real white tongue can cause anemia, and it also could be from like certain drugs, can really dry it out, or dehydration.
Dehydration.
Yeah.
I think he's got a lot
He had
of
low
stuff
blood
going on.
pressure, he was
Did he?
pretty low, yeah.
Yeah, so he's got lack of perfusion somewhere.
Have you seen his tongue?
I thought he
No.
overdosed because his wife said he was taking his pills again,
I don't know.
but he was just on like a blood pressure medicine.
Oh, really? Yeah, so,
Yeah, he's presenting like he overdosed on something. though.
really?
Yeah.
Yeah, so that's kind of what you do, is you just go down your AEIOU tips and kind of figure it out. The best one to fix the quickest is insulin, all right? So, he's shaky, unresponsive.
He should rearrange it, be spit, TIU.
So he's got a blood pressure 110/70, pulse is 100, respiration is 20, glucose is 75 off the IV cap.
Uh-oh.
Heart, normal sinus, neuro, he's moaning, not following commands,
checking
pulse
that
ox
sugar.
is 96. It's like, okay, we checked the sugar,
I'm checking it again.
and it was good.
Sure.
And, you're like, okay, the patient's got a gag, he's got good stats vitals, poor mentation, what is going on? Is this a stroke? What's going on? Cause you've done everything, the problem is this.
Yeah, I'm rechecking it.
Check out the other
Something
end.
doesn't seem right there.
Yeah, something's not right.
I'd have to say though, we would check a finger stick before we start the IV and something.
All right, so you repeat the glucose.
I would.
Sometimes.
And since the IV's already in place, you do a cap stick, and it's 42.
Yeah.
So what do? Give sugar, and what should he be?
Stuff a cookie.
Gluten oriented.
Sprinkle sugar
Yeah.
packets on his tongue.
Yeah, like Seinfeld episode,
Yeah,
remember they were
who
putting
stuffed cookies in his mouth?
Don't do that. So he's happy again. Okay, isn't this like that dirty old man from one of them TV shows or something?
Yeah.
Yeah,
From Family
I
Guy?
don't know.
Six boys.
It's
Yeah.
Walter
I don't know,
from,
but anyway, so can this patient sign off?
Jeff Dunham.
Well-
Jeff Dunham.
Can you sign off?
Sugar, sure.
Why don't you give him sugar?
That guy's with less teeth.
You know, the thing with the safer profound hypoglycemia from insulin or older hypoglycemic medication, try to get him to go to the hospital if you can, just because, something going on with the sugar, things like that, what caused it. But yeah, really stay away from the venous. And this is what we were talking about. The plasma concentration from whole blood has less plasma than capillary blood. Glucometers are calibrated for capillary blood samples. Usually you want to kind of use the IV caps just because it seems like a natural thing. You really need to do either the middle or the ring finger. Those are the two best. Are your middle and your ring.
Gonna bust the budget with lancets? No.
And this is what we talked about. And this is actually from the glucometer instructions. This is what you were asking me. You were asking me about the instruction booklet. Yeah, it's here. The Assure Platinum Blood Glucose Monitoring System is intended for the quantitative measurement of glucose in fresh capillary whole blood from the fingertip.
Were you picked up by a squad and did they check the sugar?
Okay,
I didn't.
so make sure
All free
it's
Frank
there.
and
And then it's gonna save, so first it's gonna help your patient, and second it's gonna help you guys not get nailed at in the ER. You said you checked the sugar, we did.
They never asked Claire though, so
Right.
we're in the clear for that.
Yeah, but I mean, at least you're not hearing about it, you know, and it's
Yeah.
helping your patient, that's the biggest thing, so, yeah, make sure you go to that. And this was a study that was done, so, they actually figured it out, so sometimes you can get some weird numbers, it's different. So, make sure everybody knows, so finger sticks, use middle or ring, don't use your index, cause people tend to have like more, calluses on their index too, if they're smokers, you know, that kind of stuff, so just use your middle and your ring. But capillary is the best way to go. And we are done,
Yeah,
okay?
real quick
Oh,
question
and
about
if you
that.
wanna go to the symposium, go on May 20th.
You know, they tell you to clean it, and then once the blood comes out, you clean it again, and then you get the sample out of there. How much does the alcohol really affect the reading of that, or if any?
I don't, I think if you were doing like if you were doing a,
You
what
were
do you call it?
cleaning with alcohol, and you were taking the blood from the wrong spot.
Yeah.
We were screwing it up all over the place.
Yeah,
I
I'm
think
just
it would
saying,
affect
is it
more
really,
like a blood alcohol level,
it shouldn't affect the sugar.
but I
level.
don't think it should affect the sugar.
Say that,
Do you have to use alcohol prep? I mean,
Well, these are people's fingers, you don't know where people's fingers have been.
Yeah.
They could have a cookie jar full of sugar.
Yeah,
and
'cause we all know they
I remember
reuse their
all-
testing supplies anyway.
Right, you know, that's the big thing,
Yeah.
so, yeah, but you clean it off and, you know, don't blow on it, you know what I mean, I always got a kick out of that,
No, I was just wondering, cause I was always curious, you know.
Now, if you were doing a blood draw for, you know, a BAL, a blood alcohol level,
Uh-huh,
they wouldn't, they'd throw it out of court if you
Yeah.
used an alcohol pad, you have to use like iodine or something like that.
for,
okay.
blood cultures too,
What?
for blood cultures in the hospital, you can't use alcohol, correct?
I think there's particular ones you can't
So
and
we've taken them
particular
in, they
ones.
asked if we used alcohol to clean the IV site, and we said, yeah, and we took it.
Yeah, there's particular ones that you, if they're looking for, that the alcohol will affect, but some you can, some you can't. It's gonna depend on what they're actually looking for, and I know a lot of it is the blood alcohol levels, cause they'll get thrown out in court. So,
So then if you get pulled over for.
you missed it,
As you're allergic.
when you check a sugar, you don't check it from the IV, the
You have
venous.
to use alcohol.
You have to do
Yeah.
capillary, middle or ring finger.
Okay.
Your machines are not calibrated for venous, so your numbers are gonna be off.
Okay.
So they actually might be higher here, and then when you get to the hospital, they do a cap stick, and they're like lower.
I took my last two today.
Yeah, your
Don't
machines.
feel bad, we all do
Yeah.
too.
Yeah, well, here, but I was just showing them, the machine actually
Okay.
in the instructions says it's fresh capillary whole blood.
Okay.
Does it
So
affect the
remember
reading?
that.
That's what I thought.
Yeah, it was
Always
done.
does.
Done.
Are you done?
Yes.